This recorded lecture will be going over Chapter 14, Care of Patients with Disorders of the Lower Respiratory System in the MedSurg textbook. Acute bronchitis is often an extension of an upper respiratory infection involving the trachea. This is known as tracheobronchitis. It is typically viral in origin. Early symptoms of acute bronchitis are similar to those of the common cold. Cough producing some sputum is the most common symptom. Sore throat, runny or stuffy nose, headache, muscle aches, and fatigue are also typical. The healthcare provider will rely on history as well as signs and symptoms for diagnosis. Symptomatic treatment would include humidification using either warm or cool, moist air. Cough suppressants or bronchodilators can be used to reduce coughing and soothe the irritated tracheal and bronchial mucosa. Rest is recommended to prevent progression from an acute condition to a chronic one. Antibiotics should be used if sputum culture identifies specific bacterial organisms. Influenza is an acute, highly infectious disease of the upper and lower respiratory tracts that occurs in isolated cases or in epidemics. There are 4 major types of influenza viruses, A, B, C, and D, and there are numerous subtypes. Types A and B are responsible for the seasonal disease epidemics that occur each year. Type C will cause a mild respiratory illness and does not cause epidemics. Type D affects cattle. Seasonal flu is spread by direct and indirect contact with infected people, by coughing or sneezing, and the virus is transferred from contaminated hands to objects. It is extremely virulent, and it usually affects young adults first, then will spread to the very young and very old within the community. The influenza virus affects the respiratory mucosa, causing inflammation and destruction of tissue. This will shed the virus into those secretions. The damaged tissue will provide an environment for growth of bacteria that can cause a secondary infection. The first symptoms of influenza will appear suddenly, 2 to 3 days after the initial exposure. It'll include a headache, fever, chills, and muscle aches. Sore throat, hacking cough, runny nose, nasal congestion, sensitivity to light, nausea, vomiting, and diarrhea can also occur. The virus is typically shed for 1 or 2 days before the onset of symptoms. Diagnosis is usually based on clinical findings. To confirm this diagnosis, a viral culture, serology, rapid molecular assays, or rapid influenza diagnostic tests that are antigen detection assays can be used. Antibiotics are given only if there is evidence of bacterial infection secondary to the viral infection. Bacterial pneumonia is a potential complication of influenza. Antiviral medications can be used in specific patient populations. If a person is known to be at a high risk of influenza and have been exposed to type A, the healthcare provider may choose to provide prophylaxis with an antiviral agent such as Simitril, Flumetidine, Relenza, or Tamiflu. These drugs need to be started within 48 hours of the onset of symptoms. Uncomplicated influenza can typically be managed more effectively by nursing interventions than by drugs or other forms of medical treatment. Nursing interventions for patients with flu-like symptoms would include increasing the oral intake to at least 3,000 mL per day, encouraging the patient to take analgesics when discomfort first appears, offer saline gargles for a sore throat, administer suppressant cough medicine at bedtime and during the night as prescribed. Perform mouth care every 4 hours. Cater to the patient's food and drink preferences within the limits of dietary restrictions. Give antipyretics and use cooling measures to reduce a high fever. Humidify the inhaled air. Splint chest and abdomen with a pillow during coughing attacks. Apply emollient to the lips and nares. Clear the nostrils as much as possible to prevent mouth breathing. Provide for periods of uninterrupted rest. Protect from and monitor for secondary infections. Teach frequent hand hygiene after coughing or handling any used tissues. Pneumonia is an extensive inflammation of the lung with either consolidation of the lung of the tissue as it fills with exudate or interstitial inflammation and edema. This can affect one, most common, or both lungs. In 2017, 49,157 people died of pneumonia within the United States. It is the eighth leading cause of death in the United States. Bacteria or viruses can cause pneumonia. Bacterial pneumonia is more common, and it is associated with greater symptoms and risks. Pneumonia is classified as community-acquired or hospital-acquired. Any respiratory infection in an already debilitated patient can have severe consequences. Streptococcus pneumoniae is the most common cause of bacterial pneumonia. Pathogenic microorganisms are always present within the upper respiratory tract. Pneumonia can occur when resistance is lowered by some other factor, such as chronic disease, alcoholism, debilitation, physical inactivity, or extremes in age. In many instances, pneumonia occurs after an influenza infection. Pneumonia also can result from inhalation of irritating gases, known as chemical pneumonia, or accidental aspiration of foods or liquids that will cause a pneumonitis progressing to pneumonia. This is known as aspiration pneumonia. Hypostatic pneumonia can result from lying in bed for an extended period of time due to lack of physical exercise and inadequate aeration of the lungs. People who are older than 65 years of age and those with chronic respiratory disease should receive the pneumococcal pneumonia vaccine. A variety of nursing interventions can help prevent pneumonia. This would include strengthening the patient's natural defenses and, of course, avoiding any infection, ensuring frequent turning, coughing, and deep breathing for any postoperative patients, watching for vomiting and initiating a side-lying position for any patient with decreased consciousness, maintaining elevation of the head of the bed at 30 to 40 degrees, avoiding thin liquids for patients who are at risk for aspiration, faithfully following principles of cleanliness and asepsis whenever caring for debilitated patients that are more susceptible to infection, encouraging the pneumonia vaccine for those most at risk to develop the disease, and encouraging immunization against influenza. Patients at risk for healthcare-associated pneumonia. Patients are at risk for healthcare-associated pneumonia. These at-risk circumstances would include hospital-acquired pneumonia or ventilator-associated pneumonia. In this case, pneumonia would occur 48 to 72 hours after endotracheal intubation. HAP is a major problem. This will lengthen hospital stays and increase the cost of healthcare. VAP is the most common healthcare-associated infection. However, vigilant and aggressive nursing and respiratory care can greatly decrease the incidence of VAP. People who are taking gastrointestinal acid suppressive therapy should also be educated that this can make them more susceptible to community-acquired pneumonia. This research shows that long-term use will increase the risk of pneumonia, particularly in an older adult population. Normal gastric acid should prevent pathogens from colonizing in the upper GI tract, where they can then be introduced into the respiratory tract. In typical infectious pneumonia, there is usually a high fever accompanied by chills, a cough that produces a rusty or blood-flecked sputum, sweating, chest pain that is made worse by respiratory movements, and a general feeling of malaise and aching muscles. Diagnosis is confirmed by chest radiograph, which will reveal the densities in the affected lung. In atypical pneumonia, also known as walking pneumonia, body temperature can be normal or even subnormal. Breath sounds can be normal with perhaps only occasional crackles or wheezes, and there may be no pleural involvement, therefore no pain, dry cough, or feeling of extreme fatigue. Typical pneumonia is treated with IV or oral antibiotic agents, including erythromycin, macrolides, cephalosporins, aminoglycosides, or fluoroquinolones. Pneumocystitis jirovecii, previously known as PCP infection, is associated with AIDS. This is treated with Bactrim, given IV or orally depending on the severity of the infection. According to practice guidelines, the first antibiotic dose should be administered within 4 hours of presentation, whether the admission diagnosis is community-acquired pneumonia, among other conditions. The timeliness of antibiotic therapy is related to decreased mortality rates. On page 298, see the green complementary and alternative therapies box regarding treatment for pneumonia. Barberry root bark can be used against bacteria, fungi, and viruses, as well as other organisms. This can provide an alternative treatment for pneumonia. Nursing care for a patient with pneumonia should include interventions such as promoting oxygenation, controlling elevated temperature, maintaining nutritional and fluid intake, providing adequate rest, monitor vital signs and respiratory status, relieve pain and discomfort, provide good oral hygiene, prevent irritation of the lungs by smoke or other irritants, and avoid secondary bacterial infections. The patient should breathe deeply and cough 5 to 10 times every hour while awake in order to prevent atelectasis, which can lead to pneumonia. Unless contraindicated, their fluid intake should be increased to 2,500 to 3,000 mLs per day. For young adults, convalescence with rest should extend for at least a week after the acute symptoms have subsided. Older adults will require several weeks before they can resume usual activities without experiencing fatigue. Atelectasis is an incomplete expansion or collapse of alveoli. This can occur due to compression of the lungs from a lesion in the thorax, a decrease in surfactant, or bronchial obstruction that will prevent air from reaching the alveoli. This is typically a reversible condition. Breath sounds will be diminished when the airways are collapsed, and the oxygen saturation will decrease. Treatment will consist of expelling the secretions via coughing. Deep breathing and the use of the incentive spirometer will help keep these alveoli open and functional. The most common fungal lung infections are coccidiomosis, aspergillus, and histoplasmosis. Exposure will occur by inhaling dust during desert recreational activities or when working in occupations that require digging in the dirt. Typically, there are no symptoms or mild respiratory symptoms, but 40% of patients will have a cough, fever, pleuritic chest pain, myalgias, and arthralgias. A wide variety of diseases is possible, from an allergic response to an invasive form causing sepsis. Symptoms would include cough, wheezing, fever, and dyspnea. Histoplasmosis will occur in central and eastern portions of North America. The fungus lives in moist soil, such as that in which mushrooms would grow, on the floors of chicken houses and bat caves, and in bird droppings. Clinical signs are fever, fatigue, cough, dyspnea, and weight loss over 1 to 2 months. Other fungal respiratory infections, such as blastomycosis, cryptococcosis, and candidiasis, are seen mostly in immunocompromised patients or those living with cystic fibrosis. Fungal infections are diagnosed by history, signs and symptoms, and a positive skin test reaction to the fungus or serology testing. Pulmonary tuberculosis is an infectious disease characterized by lesions within the lung tissue. The causative organism is the true tubercular bacillus, Mycobacterium tuberculosis. Latent TB infection, or LTBI, will refer to an infection with M. tuberculosis, but no current active disease. LTBI can develop into active TB if the immune system is weakened by a serious illness, such as HIV, or when the system is less efficient, such as advanced age. Tuberculosis is spread through airborne particles that carry the TB bacilli and are inhaled by a susceptible individual. These droplets can remain suspended in the air for several hours. Tuberculosis is a major health problem throughout the world. It is in the top 10 causes of death, and it is the leading cause of a single infectious agent worldwide. Leading cause of death from a single infectious agent worldwide. Mycobacterium is an acid-fast, aerobic, slow-growing bacillus. It takes 2 to 12 weeks for these organisms to replicate in sufficient numbers to prompt enough of an immune response to be detected by a TB skin test. In a healthy person, the initial lesions may heal and become latent before any signs or symptoms of disease occur. Over time, these tubercles will eventually calcify. In the unhealthy individual, the bacilli will spread to other parts of the lung and to other organs. The onset of TB is gradual. A patient may have an active, progressive lesion before the symptoms appear. Typical symptoms include cough, low-grade fever in the afternoon, anorexia, loss of weight, fatigue, night sweats, and sometimes hemoptysis. Persons with LTBI are asymptomatic and they will have a negative chest x-ray. Early detection of TB is of great importance because anti-TB drugs will be more effective in the early stages of the disease. The period of disability will be much shorter for the patient. They will have less complications, and we can help prevent the spread to other people. Food handlers, those working with children, and healthcare workers need to be tested periodically. Skin testing for TB can be done by the Mantoux test. In this test, 0.1 milliliters of purified protein derivative, or PPD, tuberculin is injected intradermally. This test is called the tuberculin skin test. This test is positive when swelling at the site of injection is more than 5 millimeters in diameter 48 to 72 hours after injection in people with a history of contact of infectious TB or in an immunocompromised patient. An induration of more than 10 millimeters in diameter would be considered positive in recent immigrants from other countries where TB is prevalent, in a medically underserved group, or in the homeless. For patients at low risk, an induration of more than 15 millimeters would be considered positive. A positive TST result would indicate that the person has been infected with the tubercle bacillus. However, it does not indicate whether the disease is active or inactive. It will only show that the body tissues are sensitive to that tuberculin. A positive reaction will require a need for further evaluation. Once positive, all subsequent TSTs will remain positive. 2 blood tests have been approved by the FDA, the QuantiFERON TB Gold and a T-Spot TB test. They will not distinguish between active or latent TB. They are less likely to produce false positive readings, and they require only one visit to the clinic or office for a blood draw, rather than the TST, which requires 2 visits. A radiographic examination of the chest may or may not reveal any tubercular lesions in the lung. However, calcified and healed lesions can typically be seen on an X-ray. A diagnosis of active TB is established when the tubercle bacillus has been found in the sputum or gastric washings. Gastric washings are done rarely in adults, but they are more common in children. Sputum cultures can be slow growing, and this culture will typically take 1 to 3 weeks to allow for identification of the bacillus. This culture report can also help indicate to which medications that organism is sensitive. Uncomplicated pulmonary TB is managed in the outpatient setting. Only those who are extremely debilitated or suffering from another chronic illness would be hospitalized. Treatment of active TB consists of taking at least 4 drugs for an extended period of time. These drugs are given in varying combinations and on varying numbers of days per week. The treatment protocols outline the initial 2-month phase, followed by several options for the continuation phase of either 4 to 7 months. Noncompliance is an issue due to the side effects, the requirement to avoid alcohol, and the long duration of therapy. Drug combinations that will make compliance easier for patients are available. This includes Rifamat, which includes rifampin, and isoniazid, and Rifader, which contains RIF, INH, and pyrazinamide. Effective cure can be obtained within 6 to 9 months for most patients with pulmonary TB. A new drug, predominide, seems to be extremely effective in killing the TB and is in phase 3 of clinical trials. Directly observed therapy is recommended for patients who are known to be at risk for noncompliance with therapy. DOT will involve visual observation of the ingestion of each required dose of medication for the entire course of treatment. A public health nurse will administer the medication at a clinic site. Follow-up visits are necessary for 12 months after completion of therapy and to monitor for the presence of resistant strains. A complete history and assessment of TB risk factors are needed. Nursing objectives are to control the spread of the infectious agent, promote immunity, and strengthen the potential recovery in a patient with an infectious disease. Airborne infection isolation, in addition to standard precautions, are recommended for hospitalized patients with active TB who are just beginning their drug therapy. The home care patient will not need airborne isolation because the family members have already been exposed by the time of the patient's diagnosis. Patients and families must be educated about the importance of medication compliance, as well as basic principles of infection control, including covering the mouth when coughing or sneezing, disposing of tissues and plastic bags, practicing good hand hygiene, and wearing a mask whenever in crowds until the medication can effectively suppress the infection. Sputum examinations are required monthly during treatment. When 3 sputum cultures are negative, the clinician will evaluate the effectiveness of treatment. The patient will then be considered no longer infectious and can resume work and other usual social activities. Improving living conditions and carrying out sound health practices are essential to maintaining a natural resistance to TB. The populations most at risk for contracting TB would be those with an insufficient immune system. Good ventilation and healthful living can prevent the spread of TB. It is also important that the patient would name all close contacts so that they can be notified and appropriately tested and then treated. Giving the names of the contacts can sometimes be very difficult for the patient because of the social stigma that is still attached to TB in certain cultural groups. It is possible for the tubercle bacillus to attack and damage parts of the body other than the lungs. This is called extrapulmonary or miliary tuberculosis. The areas most commonly affected would include the lymph nodes, bones, meninges, digestive system, urinary system, and reproductive system. Coal dust, dust from hemp, flax, and cotton processing, and exposure to silica in the air can all cause work-related lung disorders. An occupational history is part of the respiratory assessment. Restrictive pulmonary disorders are caused by decreased elasticity or compliance of the lungs, or decreased ability of the chest wall to expand. Obesity is becoming a major cause of restrictive lung disease. Sarcoidosis is a multi-system inflammatory disease characterized by granulomas, primarily within the lungs and intrathoracic lymph nodes. This disease will cause fibrotic changes in the lung tissue and other tissues over time. Sarcoidosis is 10 times more common in African Americans than in whites, and most cases will occur between the ages of 20 to 40. The fibrotic changes will cause a reduction in functional lung tissue. About 75% of patients will recover with treatment only for symptoms. Pulmonary fibrosis occurs from environmental pollutants, some medications, and interstitial lung diseases that will scar the lungs. Occupational inhalation of lung irritants, smoking, and radiation treatments to the chest are risk factors. Signs and symptoms are exertional dyspnea, non-productive cough, and inspiratory crackles, sometimes clubbed fingers. Diagnosis can be made by high-resolution CT scan and pulmonary function tests. Treatment with pirfenidone or nintedanib, antifibrotic medications, and for more advanced cases with sildenafil, can treat pulmonary hypertension. Lung transplantation is an option for some patients. Pleuritis, also known as pleurisy, is an inflammation of the pleura. This is most commonly caused by infection, but can also be due to medications, lupus, and rheumatoid arthritis. Pleuritic pain is sharp and abrupt in onset. It is most evident upon inspiration. A pleural friction rub can be heard. Treatment should be aimed at the underlying cause and providing pain relief. Pleural effusion is a collection of fluid in the pleural space. Pleural fluid accumulation is characterized as transudative or exudative. Transudate is a thin fluid containing no protein. It passes from cells into the interstitial spaces or through a membrane. A transudate occurs in non-inflammatory conditions that will cause changes in chest pressure. For example, congestive heart failure, chronic liver failure, or renal disease. Exudate is thicker. It will contain cells, proteins, and other substances. Exudative pleural effusion is typically a result of pleural and lung inflammation, but it can be caused by any organ system through a variety of medications. When pleuritis is accompanied by effusion of serous fluid, the healthcare provider may perform a thoracentesis. This is removal of fluid from the pleural cavity. It can be done for diagnosis as well as symptom relief. Empyema occurs when the fluid within the pleural cavity becomes infected and the exudate is thick and purulent. Most empyemas are secondary to pneumonia, but 20% are secondary to complications of thoracic surgery, chest tube insertion, or thoracentesis. Treatment would include drainage of the fluid by one or more chest tubes attached to a closed drainage system, as well as antibiotics. Obstructive pulmonary disorders are characterized by problems with moving air in and out of the lungs, contributing to air trapping, thus making exhalation difficult. Asthma, emphysema, bronchiectasis, cystic fibrosis, and chronic bronchitis are all examples of diseases that cause chronic airflow limitation. Obstructive disorders can be caused by cigarette smoking, including tobacco and other forms, and any other inhalation of irritants, chemicals, or other particles from air pollution, any agricultural chemicals, volcanic eruptions, fumes, or inorganic or organic dusts. Another factor could be genetic. Alpha-1 antitrypsin, or AAT, is a serum protein that inhibits the activity of enzyme elastase. This will break down lung tissue. In the absence of AAT, lung tissue can be more easily destroyed by this enzyme. Cystic fibrosis is also genetically acquired. Bronchiectasis is a chronic respiratory disorder in which the bronchi walls are thickened. This will occur as a result of frequent respiratory infections or inflammation. In the United States, about 1/3 of all bronchiectasis is caused by cystic fibrosis. Cystic fibrosis is a genetic disease. It is more common among whites, in which there is an excessive mucus production due to exocrine gland dysfunction. The lungs, intestines, sinuses, reproductive tract, sweat glands, and pancreas are all affected. It can be diagnosed via history, physical examination, as well as genetic testing or a positive sweat test. Lung damage occurs in CF due to excessive secretion of abnormally thick mucus, impairment of ciliary action in the lungs, airway obstruction, and repeated infections, which can cause scarring. Individuals with CF can now live into their 40s and even beyond with aggressive respiratory treatment and antibiotics. Current research has identified that the gene that causes CF can be damaged in more than one way. Calidico is a CF transmembrane conductase regulator, also known as CFTR. This medication is effective in supplying the chemicals missing as a result of a gene malfunction. These medications will treat the problem rather than the symptoms, and the progress made so far in research trials is very encouraging. It has improved the life for many patients. Treatment of symptoms would include bronchodilators, expectorants, oral pancreatic enzymes, double doses of fat-soluble vitamins, and mucolytics. A high-protein, high-calorie, moderate fat diet is prescribed. Breathing exercises and chest physiotherapy should be used daily. Lung transplantation is a possible life-saving measure. The WHO uses the term COPD to describe a condition that includes the related diseases, emphysema, and chronic bronchitis. Also related is chronic obstructive asthma. Annually, 160,000 deaths occur as a result of COPD. Smoking and AAT deficiency are causes of emphysema and chronic bronchitis. Tobacco smoke exposure accounts for as much as 90% of COPD risk. This does include smoking and secondhand smoke. Firefighters, welders, farmers, and others with repeated exposure to dust and particulate matter are in a high-risk group. Diagnosis is made by history, physical assessment, and spirometry readings before and after bronchodilator treatment. A chest radiograph is typically not useful in diagnosing COPD, but it can rule out other causes of symptoms. COPD is a chronic disorder treated with bronchodilators and anti-inflammatory agents to maintain a stable condition. Reduced exposure to lung irritants, such as open cooking fires, smoking, and air pollution, can help prevent further deterioration. Smoking cessation is very important. Pulmonary rehabilitation programs are also recommended, and supplemental oxygen can be given for hypoxemia. Respiratory rehabilitation programs can help increase exercise tolerance as well as improve quality of life. Oxygen should be titrated to maintain an oxygen saturation of 88 to 92%. COPD patients have adjusted to chronic hypoxia and to high carbon dioxide levels. Nutrition is very important for patients with COPD because the extra work of breathing will use more calories, and anorexia can be present. Extra protein will be required to repair the damaged tissues. For COPD exacerbations, IV steroids, non-invasive ventilation, and additional bronchodilators are given. For severe emphysema, surgical interventions have been shown to be helpful in selective patients. Lung volume reduction surgery can remove portions of the damaged lung tissue. Lung transplantation may be considered for patients who meet selective criteria. In emphysema, there is destruction of alveolar and alveolar capillary walls, producing emphysematous blebs. This will lead to large, permanently inflated alveolar air spaces. The air that is inhaled will become trapped, and it becomes harder to exhale the air rather than to inhale it. As emphysema progresses, lung elasticity will decrease. Dyspnea is an early symptom of emphysema. Coughing with small amounts of mucoid sputum is present, and it is more common in the morning. The diaphragm will become permanently flattened by overdistension of the lungs, and the muscles of the rib cage will become rigid, and the ribs will flare outward. This will create a barrel chest. To compensate for the loss of normal muscular action, the patient will begin to use their neck and shoulder muscles. The patient may appear anxious or tense. Early in the disease process, carbon dioxide is typically not retained, and therefore an acid-base imbalance is unlikely. As the disease progresses, both hypercapnia and hypoxemia, as well as chronic respiratory acidosis, are typically present. Treatment would include inhaled bronchodilators and steroids. Oxygen must be given for hypoxia. In chronic bronchitis, there is an excess secretion of thick, tenacious mucus that will decrease ciliary function, interfere with airflow, and cause inflammatory damage to the bronchial mucosa. Airways become edematous and narrowed, and air trapping occurs. Inflammation of the bronchi is considered chronic when a recurrent cough is present for at least 3 months of each year for at least 2 years. Symptoms can range from a mildly irritating cigarette cough in the morning with production of small amounts of sputum to a severe, disabling condition. Pulmonary function testing will reveal an increased residual volume caused by the premature closure of narrowed airways during exhalation. The retention of carbon dioxide and deficiency of oxygen will give the skin and/or the mucous membranes a reddish-blue color. This reddish color is also related to an increase in the red blood cell count, known as polycythemia. This is an attempt by the body to compensate for the chronic hypoxia. Factors implicated in the occurrence of asthma would include allergens, viruses, and other infectious agents, occupational and environmental toxins, exercise, perfumes, genetics, obesity, and emotional stress. Asthma is a chronic lung disease characterized by reversible airway obstruction, airway edema or swelling from inflammation, and increased airway hypersensitivity to a variety of stimuli. With asthma, a precipitating factor will create the inflammation of the airways. This leads to bronchospasm and edema. Dyspnea is indicative of inflammation of the airways, mucosal edema, and excessive secretion of mucus. These can all cause plugging of small airways. With bronchoconstriction, there is further obstruction and narrowing of the airways, which limits airflow. Diagnosis is by history, physical examination, pulmonary function testing, and chest x-ray. The symptoms can be continuous or episodic. Findings would include wheezing, a cough that is worse at night, difficulty breathing, and chest tightness. Unrelieved asthma attacks can become status asthmaticus, and this is very serious. Respiratory distress without a wheeze is an ominous sign for the asthma patient. This will suggest further constriction with very little air movement. Patients and nurses need to understand that an acute asthma attack can cause death from hypoxia. Asthma is classified based on the degree and frequency of symptoms and can be treated with a step system. Symptom control is managed by increasing or decreasing the treatment step as needed. The goals of medical treatment are to manage underlying symptoms and include minimizing irritation of the air passages and relieving obstruction by any secretions, edema, or bronchospasm, preventing or controlling infection and allergy, increasing the patient's tolerance for allergy, determining the best drug combinations in the smallest doses that will be able to control symptoms. Bronchodilators in the form of beta-adrenergic agonists and inhaled glucocorticoids are mainstays of therapy. Systemic glucocorticoids can be given for acute episodes. Asthma patients are taught to use a peak flow meter to determine the drug dosage needed to control the asthma, to predict the effectiveness of therapy, and to detect airflow obstruction buildup before it becomes serious and requires hospitalization. Peak flow monitoring is based on the greatest airflow velocity that can be produced during a forced expiration that starts fully from the lungs. On page 310, see the blue patient teaching box about using a flow meter. To properly use a peak flow meter, you must instruct the patient to put the mouthpiece in the mouth and then clamp the lips firmly around it for a very tight seal. Pulmonary hypertension is high blood pressure in the blood vessels of the lungs. Lung pressures can be measured during right heart catheterization using a pulmonary artery catheter. The WHO has 5 classifications based on the cause of the pulmonary hypertension. Medications to reduce pressure in the lung vasculature are given, and underlying causes must be treated. Patients with type 1 PH have the poorest prognosis, and survival rate at 5 years from diagnosis is just 57%. Cor pulmonale is enlargement of the right side of the heart as a complication of PH caused by constriction of the pulmonary vessels in response to hypoxia. To overcome the increased pressure in the lungs, the right side of the heart must pump more forcefully. This causes enlargement. Eventually, right-sided heart failure will cause systemic venous congestion. This will manifest as distended neck veins, right upper quadrant tenderness due to an engorged liver, peripheral edema, weight gain, GI distress, and ascites. Treatment is continuous low-flow oxygen and medications to treat the heart failure and the fluid overload. GERD is twice as likely to occur in patients with COPD. It can worsen the symptoms of COPD. The reflux of acid in the esophagus will stimulate the bronchoconstriction, and microaspiration can contribute to lung tissue damage. Rehabilitation and education of the patient and family are the chief long-term goals of nursing intervention. This means working with the patient, identifying specific difficulties that they're experiencing, assessing their current ability to cope with those difficulties, and then devising plans to accomplish their specific goals for improvement. To prevent frequent hospitalizations for acute flare-ups of this disease, the patient must be taught how to avoid bronchial irritation and infection, as well as how to identify complications such as right-sided heart failure or pneumonia. All patients must be encouraged to quit smoking. However, smoking cessation is critically important for those patients with asthma or COPD because quitting in the early stages of COPD can slow the progression of the disease. After quitting smoking, pulmonary function will gradually improve. After 10 to 20 years, the chance of lung cancer is again equivalent to that of a non-smoker. In addition to community resources, such as support groups and information sessions, nicotine patches, nicotine gum, nicotine nasal spray, and nicotine inhalers can help wean patients off the addictive nicotine. Work with the patient to develop a plan that seems possible to achieve. Decreasing stress levels and improving coping techniques will aid success for patients who are trying to quit smoking. Identify social settings that contribute to smoking and explore substitute activities. Encourage patients to share their decision with friends and family and ask them not to undermine their attempt to quit. Exercise can be a good distractor for the urge to use tobacco. Encouragement and praise for progress in quitting smoking are essential components of the treatment program. These patients will often need help and adjustment to alterations in their role and lifestyle. A trusting relationship between the nurse and the patient can facilitate discussion of personal concerns, as well as providing means to explore any possible solutions or adaptations for problems they're experiencing. The teaching plan for a patient with a restrictive airway disease is extensive. It would include management of medication as well as their side effects, use of respiratory therapy measures and the equipment, management of dyspnea, control of the immediate environment, including avoidance of allergens, maintenance of nutrition, balancing exercise and adequate rest, awareness of complications, and the need for close medical supervision. Education of the patient and family can be overwhelming, so form an action plan for patient education and self-management. Most patients with chronic respiratory disease will have difficulty getting sufficient rest and sleep due to their dyspnea, anxiety, and decreased mobility. Tension and anxiety can often be relieved if the patient is taught some relaxation techniques. However, it will take a bit of practice to use them whenever the relaxation is needed. Some patients can become very agitated and talkative when they are struggling to breathe. You should display a calm attitude, stay with the patient, and encourage them to breathe, not talk. Lung cancer is the leading cause of cancer deaths worldwide. Lung cancer typically occurs in people 40 years of age or older. Cigarette smoking is the primary cause, 90% of all cases of lung cancer. A person living with a smoker has twice the risk of lung cancer as someone not regularly exposed to smoke. About 15% of men and 22% of women diagnosed with lung cancer will survive more than 5 years past diagnosis. The percentage is very low because often lung cancer is not detected until it reaches an advanced stage. Non-small cell lung cancer, or NSCLC, includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. This accounts for 85% of all lung cancers. Small cell lung cancer makes up the other 15%. Chronic irritation of the epithelial tissue in the lung can cause changes in cell structure. Common sites of metastasis for this cancer would include the brain, bone, and liver. At first, there will be only a few symptoms, typically just a cough and some wheezing. As the tumor grows larger, the patient can experience pain or discomfort in the chest, exertional dyspnea, and possibly the expectoration of blood-streaked sputum. Fatigue, anorexia, and weight loss are also common because lung cancer is typically advanced when it is discovered. Multiple tests are used to diagnose and stage lung cancer. This would include a chest x-ray, sputum cytology, low-dose CT, PET scan, cytology of specimens obtained by mediastinoscopy, bronchoscopy with endobronchial ultrasound, electromagnetic navigation or thoracentesis, as well as a fine needle biopsy of the tumor and video-assisted thoracoscopic surgery. Treatment is based on the type of cancer, small cell or non-small cell, and its stage. It may be possible to remove the affected area of the lung by surgery if the malignancy is in its earliest stages and is localized. Lobectomy is the most common procedure used for SCLC. Radiation can be used before and after surgery. However, some types of lung cancers are radiation resistant. NSCLC is very aggressive and difficult to treat. Unless caught in the very early stages, the prognosis for this cancer is not good. You must educate your patient about tests and treatments. This can help reduce their anxiety. Pulmonary embolism occurs when a pulmonary vessel is plugged with a mass or clot. Emboli can occur in solid, liquid, or gas forms and can occur from a fracture of a long bone, from amniotic fluid during childbirth, from air introduced through a central line, or from clots formed elsewhere in the body. The obstruction will cause shunting, and blood is blocked from flowing past the alveoli. This prohibits receiving oxygen or giving up carbon dioxide. The consequences of a PE can be minor or life-threatening. Older adults are especially prone to developing DVT when they are immobilized from surgery or for a major illness. Long airplane flights and sitting for long periods of time with the legs crossed are other potential causes of DVT. Most pulmonary emboli are a result of thrombus formation that become mobile and then travel to the lungs. Symptoms will depend on the size and location of the clot in the lung and whether it is one clot or multiple small clots. The general symptoms include respiratory distress with dyspnea, chest pain, cough, hemoptysis, and anxiety. Hypotension, tachycardia, or confusion can occur. A sudden onset of dyspnea and a drop in SpO2 would indicate a patient at risk of thrombus is forming a PE. Diagnosis is made by ruling out other problems, including heart failure, and by tests that would support a diagnosis of PE. Plasma D-dimer testing is recommended when a PE is initially suspected. A computed CT pulmonary angiography scan can be ordered unless it is contraindicated. In that case, a VQ scan should be performed. Oxygen therapy should be initiated to decrease hypoxia. Treatment will depend on the size and location of the embolus and the stability of the patient. Intravenous heparin is typically begun in patients who may require invasive tests or treatments, or when long-term therapies have not been decided. Thrombolytic therapy using alteplase or retiplase is reserved for large emboli that will cause hemodynamic instability. Initial care for a patient who might be experiencing a PE is to remain calm, stay with the patient, raise the head of the bed to a high Fowler's position, begin oxygen therapy to maintain the oxygen saturation above 92%, assess vital signs, notify the healthcare provider of the patient's symptoms, start a peripheral IV, and administer IV or subcutaneous heparin when it is ordered. Prepare the patient for diagnostic tests and probable treatment. Prevention is the best intervention, and DVT prophylaxis needs to be implemented for all inpatients. A scoring system will be used to determine high-risk and low-risk patients. Type 1 pulmonary hypertension is known as pulmonary arterial hypertension. All others are labeled just as PH. The classic symptoms include dyspnea and fatigue. Other symptoms include chest pain with exertion, dizziness, and syncope. There is no cure for PH, but treatment can improve or relieve symptoms and increase the quality and length of life. Treatment of an underlying cause can help improve symptoms. Drug therapies are concentrated on lowering pulmonary pressures by vasodilating the vessels. Lung transplantation is a viable option for a variety of end-stage lung diseases. Patients must undergo extensive evaluation and psychological counseling, as well as meet stringent criteria. There must be no history of malignancy within the past 2 years, no active TB, no substance addiction for 6 months, and no renal or liver impairment. The most common cause of death after lung transplantation is infection. This typically occurs within 4 to 6 weeks of the surgery. Immunosuppressive therapy is lifelong in order to prevent the organ rejection. The major complications of chest trauma involve either the lungs and air passages or the heart and major blood vessels, and the patient's condition can deteriorate rapidly. Major concerns in the care of patients with chest injuries would include the maintenance of an airway, ensuring adequate ventilation, and treatment of any circulatory problems to ensure the circulation of oxygenated blood. Pneumothorax and hemothorax often occur as a result of blunt, non-penetrating, or penetrating injury to the chest wall. These conditions can cause partial or total collapse of one or both lungs. Pneumothorax is a threat in chest injury and is usually present in the period after thoracic surgery. The condition can also occur spontaneously when there is a rupture of alveoli. This is known as spontaneous pneumothorax. Tall, thin people and smokers are more prone to a spontaneous pneumothorax. Cases of spontaneous pneumothorax have also occurred after scuba diving, flying, or mountain climbing. A pneumothorax may require nothing more than rest and the administration of oxygen to relieve discomfort. If the amount of air in the pleural space is minimal, a large bore needle can be used to aspirate it, or a one-way chest valve may be placed. For greater amounts of air or fluid, a thoracostomy or chest tube can be inserted and connected to a water-sealed drainage system to remove air and allow re-expansion of the lung. Hemothorax is the presence of blood within the pleural cavity, typically caused by laceration of the lung, heart, or blood vessels within the thorax. The accumulation of blood in the pleural cavity can cause partial or total collapse of the lung. The patient may complain of sudden chest pain or a feeling of tightness in the chest. There is an increase in both pulse rate and the rate of respirations, a drop in blood pressure, and the absence of normal chest movements, and absent or diminished breath sounds on the affected side. Pulmonary edema is an abnormal collection of fluid in the interstitial spaces of the lung and inside the alveoli. Acute pulmonary edema is a medical emergency. Pulmonary edema is classified as cardiogenic or non-cardiogenic, depending on the cause. Nursing care will involve placing the patient in a high Fowler's position. Oxygen should be started immediately, and CPAP or intubation may be necessary. Furosemide can be given for fluid diuresis, and morphine will reduce anxiety as well as the workload on the heart. You must closely monitor intake and output and perform continuous respiratory and cardiac assessment to evaluate the effectiveness of treatment. Acute respiratory distress syndrome, also known as ARDS, is a form of acute lung injury that will result from pulmonary changes that can occur with sepsis, major trauma, major surgery, or any critical illness. ARDS is particularly dangerous when a patient has multi-system disorders. The mortality rate in these patients is 25 to 40%. Dyspnea, tachypnea, tachycardia, and hypoxemia will occur. Auscultation can reveal fine, scattered crackles. As ARDS progresses, the symptoms will worsen due to increased fluid accumulation and decreased lung compliance. The onset can be as soon as 12 to 48 hours after the initiating event. Diagnosis is made by physical presentation, history of a disorder or event known to cause ARDS, ABG determination, and chest X-ray. The chest X-ray can show bilateral infiltrates. This is sometimes called a whiteout in the absence of heart failure. The PaO2 is measured and will be divided by the fraction of inspired oxygen. If the result is 200 or less, the diagnosis is ARDS. Results of less than 300 are a diagnosis of ALI. Treatment of ARDS is ventilatory support with low tidal volumes to prevent additional pressure-related lung injury. Positive end expiratory pressure, also known as PEEP, or CPAP. Treatment of the underlying disorder, careful fluid and electrolyte management, and total care for basic needs. Drug therapies have not been shown to be an effective intervention for ARDS. Enteral nutrition is the preferred route of administration. Prone positioning has also been shown to improve oxygenation, but not overall survival. Patients with ARDS will be on mechanical ventilation in an intensive care setting. Respiratory failure is the result of insufficient oxygen or excessive carbon dioxide. This disorder can occur acutely or as in a chronic condition. Hypoxemic respiratory failure, also known as type 1, will occur when the partial arterial oxygen is less than 60 and a normal or low partial pressure of carbon dioxide is present. In hypercapnic respiratory failure, also known as type 2, the PCO2 is greater than 50. It is common for hypoxemia to be present in type 2 respiratory failure. If the respiratory centers in the brain are continuously exposed to higher than normal levels of carbon dioxide, like in COPD, they will become less reactive and a drop in the respiratory rate will occur. Many patients live in a constant hypoxic state and are always short of breath. Signs and symptoms of respiratory failure include restlessness, agitation, or confusion. An increase in respiratory rate, pulse, and blood pressure will signal a physiologic attempt to compensate for the inadequate oxygenation. Cyanosis is a current late sign of hypoxemia. The outcome can be cardiac arrest from respiratory acidosis. Respiratory failure is treated with oxygen and respiratory therapy, including mechanical ventilation, non-invasive ventilatory support, measures to reduce and remove secretions, drugs to reduce bronchospasm, airway inflammation, and correction of acidosis. Treatment of the underlying cause is also necessary. Acute respiratory failure will be managed in an intensive care unit setting because mechanical ventilation is typically required. Intrathoracic surgery, such as resection of the lung tissue and other pulmonary structures, will require opening of the chest wall and entering the pleural cavity. VATS is replacing the standard thoracotomy. This is an incision with entry into the thorax for many procedures. About 70% of thoracic procedures, including pulmonary resections, biopsy, or resection of the mediastinal tumors or masses, including drainage of pleural effusions, can be performed in this manner. Several incisions are made to introduce the scope, camera, and necessary instruments. At any time, a VATS procedure can be converted into an open thoracotomy if needed. Assessment of the patient's respiratory status before the thoracic surgery will depend on whether the surgery is elective or emergent. Preoperatively, efforts should be made to improve the respiratory status of the patient as much as possible. When a standard thoracotomy is to be performed, arm and leg exercises should be taught preoperatively to prevent thrombophlebitis and problems with movement. Preoperative patient education will focus on teaching information to improve lung ventilation and to prepare for postoperative equipment such as chest tubes, suctioning, mechanical ventilation, and the use of an incentive spirometer. During the immediate postoperative period, nursing assessment and intervention focuses on routine positioning, turning, coughing, and deep breathing, procedure-specific observations, and attention to chest tubes and the closed drainage system. A patient who has had thoracic surgery should be ambulatory as soon as possible. An advantage of VATS is that the patient is out of bed and into a chair within 4 to 6 hours of the surgery. The pain is less. A standard thoracotomy patient has a 4 to 6 weeks recovery, whereas the VATS patient can resume activities of daily living within 3 to 4 days and can even return to work within 1 week. Adequate pain management will facilitate deep breathing and mobility, both of which are essential in preventing postoperative complications. Special observation should include watching for signs of pneumothorax, hemothorax, or both, observing for symptoms of respiratory distress, and auscultation and palpation of the upper chest and neck for any swelling caused by subcutaneous emphysema. This is an accumulation of air or gas under the skin. It can feel like bubble wrap upon palpation. Subcutaneous emphysema is also called crepitus, and this can occur whenever air leaks into the tissues around the chest tubes. Inspecting the drainage system for air leakage is essential. Assessing for signs of infection, both respiratory and incisional, is also a nursing responsibility. Gastric distension and paralytic ileus are possible complications of a standard thoracic surgery. Distension of the stomach and intestines is particularly hazardous for a patient who has had a thoracotomy. This is because the distension can cause these organs to push up on the diaphragm and impair the ventilation, which has already been compromised by the surgery. Positioning for comfort, optimal ventilation, and adequate drainage of the operative site is important during post-thoracotomy care. When the patient has a tube inserted for drainage from the operative site, lying on the operative side will facilitate the flow of drainage. Care should be taken during positioning to prevent any kinking of the chest tubes. Over time, the body will accommodate for the space previously occupied by the lung. However, in the immediate postoperative period, certain positions can put stention on the bronchial stump. The surgeon preference will dictate acceptable patient positioning for any thoracic surgery. There are 3 major areas of assessment for patients with chest tubes and closed drainage systems. First is the respiratory status of the patient. Next, assess the site at which the tube is inserted into the chest and look at the length of the tube. Examine it for any kinks or clots. Then look at the amount and character of the drainage in the collection chamber. The patient should be assessed for ease of breathing, pain, level of consciousness, and anxiety and restlessness. The entry site should be assessed for unusual drainage, infection, integrity of sutures, and the presence of subcutaneous emphysema. Commercial disposable plastic water-sealed drainage systems are the most common. The drainage system should provide for drainage of air and blood from within the pleural cavity and allow for gradual re-expansion of the lung by isolating the intrathoracic pressure from atmospheric pressure. Note that the water in the left-hand chamber serves as a suction control chamber. When the unit is attached to wall suction, there will be bubbling in the compartment. The level of fluid will determine the amount of suction applied to the chest. Slow, gentle suction is adequate. The middle chamber is the water-sealed chamber that prevents air from entering the chest cavity. Tidling, which is movement with breathing, should occur in this chamber. If air is being removed from the chest tube, bubbles may be observed in this chamber. When caring for patients with a closed drainage system, you should keep the following precautions in mind. Remember that the pleural cavity is an airtight compartment. All connections must remain airtight at all times, and all connections should be taped. Do not allow the tubing to become kinked or obstructed. Never pin the tubing to the bedclothes. Do not empty chest tube drainage containers. The system must always remain closed. Instead, replace the unit when the drainage chamber is full. This system will operate by gravity, and it must remain below the patient's chest level at all times. The amount of drainage expected will vary according to why the tube was inserted, so find out from the surgeon how much drainage is expected and when they should be notified. If the chest tube becomes attached, do not clamp the tube. Place the end of the tubing in a container of sterile water. This will create a water seal and can prevent a tension pneumothorax. Persistent bubbling in the water seal chamber will indicate an air leak. Fluid in the chamber should fluctuate with inhalation and exhalation. A puffed up appearance of the patient's chest or neck could be subcutaneous emphysema. Dressings may be reinforced, but are not changed except by order of the surgeon. Dressings must be occlusive and not allow air in or around the chest tube. Other devices such as a flutter valve or Heimlich valve can be substituted for chest drainage systems. Ambulatory patients may be using a small portable chest drainage system that only has one chamber with a dry seal and does not contain any water. There are several other devices available for chest drainage for home care patients, and each will come with its own specific care directions. A dry suction system is sometimes used in place of water seal suction. It provides more consistent flow because the suction adjusts automatically to changes in the patient's pleural pressure or to fluctuations in wall suction pressure. On page 319, see the question on Think Critically in the blue box. Your patient is 1 day postoperative from an open thoracotomy. What would you do if the fluid in the drainage chamber in the closed drainage system had not increased over the past 4 hours? A good intervention would be to check that tubing for kinks. The patient should be medicated 30 to 60 minutes before the removal of a chest tube. When the surgeon removes the chest tubes, the incision is covered with a dressing containing sterile petroleum jelly to close off the opening. This is so air will not enter the pleural space. This type of dressing should also be applied if the chest tube has been accidentally pulled out. Auscultate the lungs after chest tube removal to verify that a pneumothorax has not occurred. Bronchodilators are drugs that directly act on and relax the smooth muscle of the bronchi, and therefore they relieve bronchospasm. Liquefying agents can help thin bronchial secretions, making them less tenacious. Corticosteroids are a major part of inhalation therapy for patients with COPD. Inhaled steroids at doses used routinely for COPD and asthma are not significantly absorbed systemically, and they will not produce the same side effects as oral steroids. Acute respiratory problems can be treated with systemic corticosteroids, either oral or IV. Blood glucose should be closely monitored for elevation. Antihistamines can be used to treat respiratory symptoms of an allergic disorder. They will reduce secretions and swelling of the nasal and bronchial mucosa. Leukotriene inhibitors and immunomodulators can help control asthma symptoms by blocking the activity of substances that mediate inflammation. Aerosols are fine suspensions of very small particles of a liquid or solid that dispenses a gas. Several delivery systems will provide aerosolized medications. MDIs, or meter dose inhalers, are used to deliver a variety of drugs to respiratory patients. MDIs deliver liquid medication, and dry powder inhalers will deliver the dose in powder form. Bronchodilators, liquefying agents, and some anti-infective agents can be administered directly into the mucous membrane via a nebulizer and a mechanical ventilator. A nebulizer can provide aerosolized medications via a mouthpiece, face mask, face tent, or tracheostomy collar. Nebulizer treatments are typically 20 to 30 minutes long and should be given 2, 3, or 4 times per day. Halfway through the treatment and after the treatment, deep breathing and coughing should be performed to raise any loose mucus. For oxygen delivery of 4 liters per minute or less, humidification is not necessary. With tracheostomies and high-flow oxygen delivery, humidification is needed. The highest humidification will be achieved with warmed fluids, although room temperature fluids can be used. Patients with chronic pulmonary disease could benefit from a program of pulmonary hygiene. This is designed to remove secretions and enable more efficient exchange of oxygen and carbon dioxide. Pulmonary hygiene programs include administering prescribed drugs, humidifying inhaled air, medication therapy via nebulizer, DPI, or MDI, chest physiotherapy, and breathing exercises. Chest physiotherapy includes postural drainage when possible, as well as percussion and vibration. Postural drainage involves positioning the patient so that the forces of gravity can help move secretions that are deep in the bronchi and the lungs. Because there is likely to be some gagging during coughing episodes that take place during postural drainage, it is best to carry out this procedure before meals. This is when the stomach will be relatively empty and vomiting is less likely. If the patient is to have postural drainage only once a day, that drainage should be done in the morning in order to remove secretions that have accumulated throughout the night. After postural drainage is completed, good mouth care, including brushing the teeth and using a refreshing mouthwash, should be performed. The purpose of breathing exercises is so that they strengthen the abdominal muscles so they can push upward against the diaphragm and assist with the expiration of air from the lungs. These exercises will also help overcome rigidity of the thorax so that the lungs can inflate and deflate more easily. Oxygen is a drug, and it needs to be prescribed and administered in specific doses to avoid oxygen toxicity. The dosage of oxygen will be stated in terms of concentration and rate of flow. Room air contains 21% oxygen. This is considered your fractured of inspired oxygen, or FI2. Every liter of 100% oxygen delivered increases the FiO2 by 3%. The amount of oxygen a patient receives will depend on the rate and depth of their breathing. Nasal cannula will provide a low flow, and it should not exceed 5 liters per minute. High-flow oxygen delivery systems will provide oxygen levels high enough to completely supply the needs of the patient. For prolonged periods of high-flow oxygen delivery, the gas must be humidified. High-flow oxygen therapy will provide oxygen from the source to a high-flow machine. In addition, humidified compressed air will be mixed with that oxygen and then delivered to the patient. Short-term oxygen therapy, which is the administration of oxygen to treat hypoxemia, will be given to achieve an saturation of oxygen between 94 and 98%. Outward signs of hypoxia will vary among patients, but dyspnea, restlessness, and confusion are the most common signs. Blood gas analysis is the most reliable indicator. Long-term oxygen therapy for patients with asthma or COPD will be used to relieve hypoxemia, reverse tissue hypoxia as well as its signs and symptoms, and allow the patient to function better mentally and physically, thereby increasing self-reliance. Nurses should check the oxygen delivery system at the beginning of the shift and then periodically to verify that the flow is set according to the healthcare provider's orders and that the target SpO2 is being maintained. Check the tubing to see that it is not kinked and that it is actually connected to the oxygen source. Oxygen is not explosive. However, it does support combustion, which means that a spark or flame could cause a major fire. Smoking is not allowed when oxygen is used. The tubing must be kept off the floor, and the connection should be handled aseptically to prevent contamination of the system. Most healthcare facilities are smoke-free institutions, but patients and families still need to be taught safety principles if oxygen is to be used at home. Open flames for cooking also present a risk. When oxygen therapy is discontinued, it is typically done gradually. The patient will be weaned from their dependence on the oxygen by gradually reducing the dosage until they can tolerate room air. Mechanical ventilation is needed when the patient cannot maintain adequate ventilation due to respiratory, neurologic, or neuromuscular problems or trauma. The pressure delivered will be greater than that within the airway and alveoli. Therefore, gas will flow into the lungs, either assisting or controlling the inhalation. When the pressure is released, exhalation is passive, without effort by the machine or the patient. An endotracheal tube or tracheostomy tube must be in place for the use of most mechanical ventilators. If the ventilator meets too much pressure, an alarm will sound to indicate that the correct tidal volume is not being delivered. This is commonly caused by excessive secretions in the lungs, and suction may be needed. In controlled mode ventilation, the machine is set to deliver a fixed number of breaths per minute at a set volume. The machine does not allow for spontaneous respirations. Assist mode ventilation will decrease the work of breathing for the patient. When the patient takes a breath, the machine will deliver a set tidal volume. If the patient's respiratory rate falls, the machine will then deliver a set number of breaths per minute. If the patient initiates a breath, the machine will finish it at the set tidal volume. The patient can actually breathe above the rate set on the ventilator. Intermittent mandatory ventilation and synchronized intermittent mandatory ventilation are the most common modes of ventilation found in most critical care settings. These will allow the patient to breathe spontaneously and yet also provide a preset number of ventilator breaths with a preset tidal volume to ensure adequate ventilation without respiratory muscle fatigue. SIMV is triggered by the patient's inspiratory effort to initiate the machine breath. In PEEP, the pressure in the airways will never fall below a certain level, typically between 5 and 15 centimeters of water. This will hold the small air passages open and limit atelectasis. PEEP is also used for ARDS and respiratory failure. In pressure support ventilation, the patient breathes spontaneously, but PSV decreases the work of drawing gases through the ventilator for tubing, therefore decreasing the patient fatigue. PSV can be used as an adjunct to standard ventilator modes. It has proven to be very beneficial when weaning a patient from IMV. CPAP and bilevel positive airway pressure, or BiPAP, can be used for patients who are breathing spontaneously but are showing signs of hypoxemia. This can be used for infants with mild respiratory distress syndrome and for adults in the early stages of respiratory failure. CPAP and BiPAP are not delivered through an artificial airway, and they are considered non-invasive positive pressure ventilation. NPPV is used in the hospital and in the home to provide ventilation assistance for patients who may need help with oxygenation or air movement. It is used only in spontaneous breathing patients who can maintain their own airway. Carefully monitor carbon dioxide levels, oxygen saturation, hemodynamic stability, level of consciousness, ability to clear secretions, and the ability to tolerate the mask or prongs. In the home setting, NPPV is used in the form of CPAP or BiPAP, primarily for sleep apnea. These delivery devices will use room air, not oxygen, for their gas delivery. The primary function is to keep that positive pressure in the airway and prevent it from closing while the patient sleeps. Delivery of supplemental oxygen is not a goal of the therapy. Care for a patient who is receiving mechanical ventilation will require extensive training and supervised practice. Mechanical ventilation can be short-term, or it could be a chronic support for those who can't breathe on their own. When caring for a patient with mechanical ventilation, you should check the healthcare provider's order every shift, then go and check your ventilator settings. Check your FiO2, respiratory rate, tidal volume, peak inspiratory pressure, and PEEP if CPAP is involved. Then check your alarms. Make sure that they're turned on. Alarms should never be turned off when disconnecting the patient to suction because the alarms may not be reactivated. Keep tubing clear of pooled water and empty the water into an appropriate receptacle as needed. Check for any tension or stretching of the ventilator tubing every time the patient is repositioned. The patient should be observed for signs of complications, including gastric distension, pneumothorax, and impaired cardiac output due to decreased venous return, as well as the need for increasingly higher pressures to deliver their set tidal volume. This can indicate stiffening of the lungs. On page 328, see the red safety alert box, preventing ventilator-acquired pneumonia. Use of a ventilator bundle will help prevent ventilator-acquired pneumonia. For ventilation to be effective, the lungs must be kept clear of secretions. Endotracheal and tracheal suctioning must be done with strict aseptic technique due to the high risk of respiratory infection. In intubated patients, an inline suction catheter is used for secretion removal. An intubated patient on a ventilator cannot talk, so alternative means of communication, like a dry erase board, vital voice communication device, electronic device, or paper and pencil, are offered. In the acute phase of mechanical ventilation, patients may be sedated. Nurses and other staff must still communicate with the patient, assuming that they can hear what's being said and explain all procedures and activities. Additional calorie intake will be needed to maintain weight when a ventilator is used. Continuous enteral feeding is the method most often used to prevent malnutrition in these patients. You should monitor their nutritional parameters. If a ventilator alarm sounds and the problem can't be located quickly, the patient should be disconnected from the machine and ventilated with a manual resuscitator bag and oxygen until the problem can be solved. Most patients diagnosed with sleep apnea are using BiPAP or CPAP machines at home, and home health nurses will monitor and teach about the use of that machine. Outpatient clinic nurses might be the first ones to notice that respiratory patients are now having an increased number of sick days and an increased severity with each episode. You can advocate for spirometry because it is a good test for detecting non-malignant occupational lung disease. Community nurses will participate in infection control by identifying and referring potential and active cases of tuberculosis within the community. Working with patients to promote compliance with their exercise and medication regimen is a primary function of the nurse in the community. Rehabilitation of chronic respiratory patients will be directed at improving breathing, improving activity tolerance, decreasing infection, and preventing acute episodes.